It's not because I'm such a good teacher, but you guys have helped that so much. But it's wonderful to hear that it's been a positive experience for most people. It's just an ideal setting, I think, in that way. Okay, Nathan says we're up and running, and now we're airing it out there, so welcome everybody, including those of you who are in your own place watching it. So this is one of a continuing series that we do on a monthly basis. You know, originally before COVID, we were doing a second presentation every month that was a little different. I call that an open mic. And that's dangerous. That's like flying without a net. You open up to be asked anything. I can be wrong about a lot of things and not have the answers about a lot of things. But once we think the COVID really is out, because I think it's if it's just questions and answers, it's hard to do that remotely. I mean, you can do it, but it's hard to make a you're not making a presentation. So. But this, which we have maintained, we've only missed once through the whole 2-year COVID thing. This is something we do, you and your health, and we try to present a topic that's of interest, so has of interest in the broad arena of your health and aging and health. Because we know they go hand in hand, don't we? So we're getting to where we're going to have to start repeating some, because all the common ones over 2 years, the ones that are really people are looking to hear about, we've already covered some time ago. The one today is, I think, particularly pertinent. It's on anxiety. You know, we all live with some degree of stress. None of us are stress-free. Although I think that's a really good goal for all of us as we get older, is to look for situations, look for activities, look for the way you spend your time as being something that's going to reduce stress, or that's part of pursuing a stress-free type of lifestyle. And it's impossible to hit that ideal completely. But you may have heard me say this before, what you don't want is to be doing things that are downers. Spending your precious time doing things that are, I say that all activity, you can classify all activity broadly into 2 areas. Activities that are energy depleting, that just sap you of energy. You feel drained, you don't feel happy afterwards, you did it. Those are largely things that you're doing for somebody else, not for yourself. Or because you ought to, because that script in your head. My mother sits on my shoulder and whispers in my ear, that kind of thing. But so energy depleting. And so there's a lot of hard work that is energy depleting for the moment. If it's aerobic, it's probably going to be energy repleting, because the other category of activities are energy repleting, things that give you more energy when you've done them. They don't exhaust you. If they do, it's only momentarily, but it's with joy. That's the way it is. But stress plays an important part, in a good way even. It's what gets us out of bed in the morning, right? A little stress. Oh gosh, I was going to do that. I told Sally I'd do that. You know. And it's something you want to do. But too much stress runs the risk of impairing our function, our ability to function in usual and important ways. And so the topic today is about anxiety and anxiety disorders, and especially in older adults, how it plays out in older adults. It's totally different in kids and younger adults. But I think our resident physicians have put together a good presentation. Let me tell you about them. I started telling you about Dr. Williams. Kayla Williams is a native of Kentucky. How did we get here from Kentucky? she told me we were just so nice when she came to interview. Gee, I wish nice would always get us that far. We'll turn up the nice volume. She's a graduate of Kentucky, University of Kentucky, and I think we all should show her special sensitivity today after what we did to their team last week. And she thanked me today for not giving her a real bad time about it. But I know she's not proud of what that team did walking off the court. I know that. I know what kind of person she is. She wouldn't be a part of that. But truthfully, she's been one of our 3 chief residents who take on extra responsibility beyond their learning activities to help manage the program, especially with their peers. Hers in particular is the hardest job. Hers is scheduling these 33 residents and where they ought to be. And that's particularly stressful. Speaking of anxiety, that alone could probably give you fodder for this conversation. But she's had such a wonderful 3 years here for us. Her years of service have been remarkable, and the faculty's very, very proud of her, and she's most popular with her peers. Now contrast that from University of Kentucky with Dr. Solomon, who's a graduate of the other UK, but it goes by KU in Kansas City, actually, yeah. And so, and then to UAMS. So it's actually in Lawrence, isn't it?
Yeah.
Yeah. So Lawrence, undergraduate there, and then he came to UAMS. Dr. Solomon, if that name sounds familiar, his father practices in this community. He's a cardiologist, one of the electrophysiologists. So I bet there are a few of you who've met him. His growing up was a matter of following his father's training and practice venues. So his father immigrated from Egypt, had gone to medical school in Egypt, and came to this country. And so he was born in Brooklyn and then grew up in a small town outside of Springfield, Illinois, before they moved to Fayetteville when he was 17 years old. And so his father is the famous Dr. Solomon at the Walker Heart Institute. Here's the future famous Dr. Solomon. So Muhammad Solomon, who is referred to affectionately as Mo. So, and I bet there have been Big Mo sometimes.
No, absolutely.
I feel safe when I walk around with him. I feel safe. So with that introduction, just to say that these are 2 of the sharpest residents we've had, and we're all just very proud of them. And I think this presentation you'll find helpful. So with that, I think, Dr. Williams, you were going to go first.
Well, it's good to see you guys. Thank you all for coming out to hear our talk.
I'm never through talking. I'm very sorry. For those at home who might want to ask a question, let me just tell you the phone number. The phone number is 479-200-9259. And Mo will answer it, or whichever one of them's not talking will answer it and take your question, and we'll try to answer it.
All right. So like he was saying, I kind of felt like this topic was particularly pertinent right now. I think the majority of our training has been during the COVID pandemic and all the social isolation and the uncertainty of how things are going. And for my part, I've seen a pretty big incidence of anxiety in the clinic. And so I thought it might be good to address it in case any of you all are experiencing it or want to know more about it. The first thing to clarify is that there are really kind of 2 classes of anxiety, one of which we would call secondary anxiety, which can be due to other medical conditions or medication side effects, situational, that are not necessarily an anxiety disorder. They're just a product of a medication that you're putting in your body that doesn't agree with you, or something like a heart attack or something, more severe going on. We're going to talk more about the actual anxiety disorders today, not so much the side effects secondary anxiety. The anxiety disorders are actually the most common psychiatric condition that we see in the country, and 15 to 20% of our clinic patients experience some form of anxiety disorder. So very important to discuss today. And I've got the ones listed up here we're going to talk about. I think most people are pretty familiar with generalized anxiety disorder and panic disorder. Those are probably two of the more common ones, panic attacks. But some of these other ones are a little less common, and maybe you haven't heard of them, so hopefully we can help you learn something today.
Alrighty, so we're going to start off. Go to the next slide, please.
Yeah.
Alrighty, so we're going to start off with generalized anxiety disorder, and like Kayla said, that's something that a lot of us are pretty familiar with. And you'll see with most of these anxiety disorders, they typically start when we're young. And they can be due to, issues in the family. It could be due to things you experience, in daily life. For generalized anxiety disorder, it usually occurs before the age of 20. And it's prevalent in about 5 to 12% of the population. It's more common in women than in men, and about 60% of the time, people have a comorbid psychiatric condition, such as depression or some of the other anxiety disorders that we're going to talk about. And this is the most common psychiatric disorder in the geriatric population. And it can occur late onset. You may realize that, some of you may not have ever really experienced anxiety before, but, it can come on late. And that's not unusual. And things that can kind of lead to this include poverty, recent adverse life events, chronic physical illness, parental loss or separation, and family history. And so some of the things that we see with this, some symptoms, include kind of persistent, excessive worry associated with muscle tension, impaired concentration, and difficulty sleeping. You can also see your heart racing, you're sweating a lot, dry mouth, some of those symptoms to kind of worry you even more. And to be diagnosed with generalized anxiety disorder, you have to have these symptoms for at least 6 months. And it is important to notice that this condition is commonly among patients with medically unexplained chronic pain. So if you have chronic pain due to something that we're not entirely sure, it may be due to anxiety. So different ways to treat this, and it's important to note that there are medical and non-medical ways to treat anxiety or any condition, and that the best way to really treat it is to combine the two together. So I'm going to start with the complementary treatments, which include CBT, cognitive-based therapy, which is a kind of therapy that has you kind of realize what is causing this anxiety and how to kind of better understand it. Also, meditation, yoga, and different aerobic exercises. I know a lot of the clinics a lot of patients I've seen in clinic, they love the different exercise classes that are provided here, and that can help with anxiety as well. As far as treatments that we can provide you, typically we start with the antidepressants, so SSRIs or selective serotonin reuptake inhibitors. They are medications that increase the serotonin in your brain, as well as SNRIs, which affect both serotonin and norepinephrine. Tricyclic antidepressants, those are all medications we typically try first, particularly the SSRIs, to try and help with anxiety. Then we may consider different mixed action drugs such as Buspar. For some people it works, for some people it doesn't, but it could be a good alternative. And then we can use benzodiazepines such as Ativan, but we are pretty hesitant to use it because, like any medication, they have side effects.
Okay. And I want to say for the benzodiazepines, that's a really commonly asked for one here. They're particularly problematic in the aging population. They come with fall risks and, foggy headedness, that sort of thing. So if your doctor's kind of fighting you on it, if you're wanting it, that's why we tend to value the risk over benefit analysis of things before we prescribe stuff. So. Yeah, so like you mentioned, Ativan is one. You've probably heard of Xanax or Valium. They are great for anxiety, but they just come with a lot of risks and side effects, especially in the geriatric populations. Okay. All right, next slide. Can't even tell this. Okay. So we're going to talk about social anxiety disorder. This is a fairly prevalent one too. Seems to actually get a little more prevalent with aging for various reasons. About 5 to 12% of the population in general has some form of it, female predominant. And if it ends up showing up earlier in life, it kind of shows up as kind of personality abnormalities, like children are really shy or just very inhibited, don't really want to interact very much, and that kind of develops into more anxiety later in life. There is a genetic predisposition with this one, so if you experience it, someone in your family probably has had it at some point as well. They are actually quite high risk for other psychiatric conditions as well, about a 4-fold increase among these people, particularly other anxiety disorders or mood disorders like depression, bipolar disorder. Particularly in the geriatric population, they can develop it when they're getting unwanted attention because of some sort of physical or behavioral changes, particularly with like Parkinson's disease, where you are starting to exhibit motor abnormalities and you have to adjust the way you do things from day to day, and it can kind of, draw attention to yourself. Or dementia, when you're really concerned that you're going to forget something and feel kind of stupid in front of somebody. Obviously you shouldn't. I think everyone has experienced that or has a loved one that's experienced that, but it doesn't make the anxiety less real for sure. One thing to note too with social anxiety disorder, there are kind of two forms of it. So there's the one that's a little more generalized that we've kind of been talking about already. There's also a performance-based version where people are very specifically afraid of certain situations like public speaking, or going to social events or dating. It's not just a generalized thing. In the geriatric population, some more specific ones are a fear of eating in front of other people or a fear of using public restrooms. I've seen that one from time to time. So there are different variations, but it's important to separate the two because you can better direct your treatment for the more specific anxieties. So for public speaking, let's say you can have what's called a beta blocker medication. So a lot of you are probably on one, metoprolol or carvedilol or atenolol. Useful for a lot of different things, but also very useful for these specific performance-based social anxieties. So if you're like me and have a fear of public speaking, if you have atenolol on hand, you can take it 30 minutes before and manage it a little better, but otherwise you don't need medication because you're not really anxious about anything else. Whereas, someone that has more generalized versions of it may need more prolonged treatment. And the treatments are kind of the same as any other anxiety disorder for the generalized version. He talked about the SSRIs, SNRIs. They are a good mix of antidepressant, anti-anxiety medication across the board, and they are the most benign forms of them, I think. There's a drug class called MAOIs, which has really fallen out of favor because they're just so fickle to use, but I put them on here just for your information. We talked about the beta blockers, and the benzos are another one that's really more meant for the performance-specific situation because, like we've talked about, they come with their issues, and they can also be addictive when they're taken regularly, so really stick to just intermittently using. And then the biggest complementary treatment for it is cognitive behavioral therapy. You'll find that CBT across the board is highly recommended for a lot of psychiatric disorders, especially with anxiety. It is a way to kind of retrain the thought processes in your brain. So to help you recognize, hey, that's not a healthy thought, and try to redirect it. And it's highly effective for this, as well as many other anxiety disorders that we'll come across here. Next slide.
Alrighty, the next one we're going to talk about is panic disorder. It typically occurs late adolescence to early adulthood. It's prevalent in about 2 to 3% of the population. And you'll notice that 75% of people have some kind of associated either depression, substance abuse, or agoraphobia, or just fear of open spaces. And this one also has a pretty strong genetic and familial component, meaning that tends to run in the family. As far as symptoms they experience with this, you have recurrent and sudden onset, like intense fear and discomfort. You may have some palpitations, sweating, shortness of breath, chest pain, being kind of not able to move your arms or leg, feeling paralyzed, upset stomach, and fear of impending doom or even death. These acute attacks, these panic attacks, usually last between 10 to 30 minutes. And in order to be diagnosed with a panic disorder, you must experience more than one attack over the course of at least 1 month. And periods between acute attacks, people tend to be really worried about when they're going to have the next one. In the geriatric population, symptoms may be more limited and may not present as wide or as much variety as what I just mentioned. It may be just one or two things, such as maybe just chest pain or shortness of breath, sweating, that kind of stuff. It may not present as notably as it would in someone who's younger. And treatments for this is pretty similar to the stuff we've talked about already. Your antidepressants, your tricyclic antidepressants, your benzos. When these don't work, we typically move to an antipsychotic like aripiprazole or Depakote. As far as complementary treatments, as far as what we can do for panic attacks, just kind of recognizing the symptoms before you have a full-blown panic attack can help others. And kind of how can you cope with those symptoms, such as taking deep breaths or breathing into a paper bag, or different ways you can try and prevent yourself from having a full-blown attack. As well as exposure therapy. If you can find one or two things that cause you to have panic attacks, the more you're exposed to it, the less it can actually cause those panic attacks. And that's what exposure therapy is aimed at. Next slide.
Okay, so phobic disorders. This is a pretty prominent one as well. I think most people have a fear of spiders or snakes or mice or something along those lines. But there are definitely more severe forms of this than most of us experience. So we'll talk about the more severe variety. Typically, this one presents in early childhood, early adulthood, as far as the severe form. 7 to 9% of the population will have some sort of disabling symptoms with it. More prominent in females, also a genetic component to it. They have a high rate of other psych disorders, kind of unique ones though, more substance abuse, eating disorders type range, more so than anxiety or mood disorders. Symptoms, we kind of talked about just a general fear of things, but they really tend to have actual panic attacks, like he was just explaining, an immediate severe anxiety reaction with exposure. And it can even impair their functioning, especially if it's something they have to experience on a fairly frequent basis. They may just decide to not get out of the house that day. And what's unique about it is that the patient realizes that their fear is unrealistic, but they can't control it, they can't do anything about it. It's kind of this knee-jerk reaction to get away from it. The best thing that you can do for it is what he was just explaining, exposure desensitization therapy. So exposing yourself to your specific trigger in a controlled environment with a therapist where your reaction to it is limited, and you do this multiple times over a prolonged period, and eventually the reaction is less severe, and you can actually manage it on your own. Cognitive behavioral therapy, like we talked about, is a good one too, because obviously the thought process is a problem. And that can actually be done in group therapy as well. Sometimes commiserating with people that experience the same thing as you is a good thing. It's really important to treat any comorbid conditions they have as well, because they won't be able to focus so much on treating this one if they're experiencing depression and anxiety elsewhere. A really big thing to note with this one is it's very tempting to just give them some of the medications we talked about with panic disorder, like the Xanax, Valium, beta blockers. They have an extremely high rate of relapse with medication alone. It's just not as effective, and it's not the way that it needs to be managed, so it's very important to get them into therapy. Next slide. I think you're good.
Oh, okay. The next one we're going to talk about is hoarding disorder. And this is one that we see as far as risk factors. It occurs more often when we get older. And it's prevalent in about 2 to 6% of the population. Different things that can kind of lead you to having a hoarding disorder is unemployment, unmarried or divorced status. About 30% have a comorbid anxiety disorder, like the ones that we've talked about, or depression. There may be a genetic component, and some studies suggest that this may occur at first earlier on, like in adolescence, but can occur later on as well. As far as symptoms, you basically have a hard time getting rid of things you don't necessarily need, regardless of how valuable they are, or essentially how much you really enjoy them, but you just have a hard time getting rid of them.
I should have included a picture of what the actual disorder looks like, because I think all of us hang on to things that we shouldn't.
And essentially, this just leads to clutter and just makes it harder to live at home. You just have so many things around you that kind of impede you walking around. And then you're also buying a lot of new stuff and not getting rid of some of the stuff you don't necessarily need or have much value in. But it can also present as extreme self-neglect in older folks as well. And the treatments, kind of more of the same. SSRIs are typically used, as well as Ritalin and Strattera are 2 medications that can be given. But another thing that we really use is CBT. You'll notice that, like I said, when you combine the two, you have a better response. Yeah, absolutely. So an SSRI would include like Lexapro or Celexa, Prozac. Some of those medications that are often given can be used for either depression or anxiety. They're pretty commonly used. And then SNRIs include, I don't know the brand names.
Cymbalta.
Yeah, Cymbalta, I like duloxetine.
That's Cymbalta.
Yeah. Oh,
Yeah,
Effexor. Sorry, I know the scientific names, but not so much of the brand names. But those are medications that typically we use after SSRIs, just because if they don't work for you, we can have another medication or type of medication to switch to. So CBT essentially is therapy used to kind of notice certain behaviors that are, that would be considered abnormal, and have you kind of recognize those and find ways to work through them.
It just helps you recognize problematic thought patterns that you have, and to be able to say, oh, that's not okay, and then replace it with something better, and in turn replace it with better behaviors based on your thought processes. It's extremely effective. As you can see, it's being utilized in pretty much all of these.
Yeah, so it's cognitive behavioral therapy.
Okay. And I would clarify too, the Ritalin and Strattera are actually typically ADHD drugs. So I wonder if there's maybe some form of ADHD involved with the hoarding, if these are effective. But, okay. Next slide. Okay, stress disorders. So the most common one that you all will definitely recognize is PTSD, post-traumatic stress disorder. You get a lot of veterans that deal with that. Anybody that goes through any traumatic experience struggles with this. There are some kind of lines to be drawn as far as definitions go. There is a form called acute stress disorder, which is very common, particularly in the aftermath of a traumatic event, but it's short-lived. And people eventually kind of recover. It's a normal grieving process, I think, and a normal processing experience. They'll have similar symptoms with flashbacks and panic attacks, but those symptoms are less than a month, and then they kind of recover and pull out of it. PTSD, on the other hand, is delayed. So if they go on for longer than a month, and they keep having recurrences of these symptoms, then you can finally kind of diagnose the PTSD officially. There is also a third form of PTSD that is kind of taking shape now. I think they finally have an ICD code for it, called complex PTSD, which is it's a response to a more prolonged trauma, childhood trauma, neglect, abuse, that sort of thing, and the way it affects their long-term cognition and their means of coping as adults. There's still a lot of research ongoing with that one, but I thought that I would mention it because I do think that it affects a lot of the people that we see. So PTSD, 5 to 10% of the population will experience it, but the acute stress disorder is a much higher prevalence than actual PTSD. Women are more commonly affected than men. There is a genetic component to this one as well. They have an extremely high rate of other anxiety and mood disorders, and particularly substance abuse. That's a really common thing we see at the VA actually a lot, is substance abuse in conjunction with their PTSD, because it's kind of a coping mechanism. They're trying to self-medicate a lot of times. So symptoms are shared across all three disorders. So anxiety in the immediate aftermath, detachment, loss of emotions, they just kind of stop experiencing life basically. Depersonalization, where you kind of become detached from who you are, detached from reality and what you're experiencing day to day, and just kind of go through the motions basically. Amnesia, they may totally forget what happened for a while until they have a flashback and suddenly relive it. They have an increased startle response, so if something loud happens around them, fireworks, gunshots, that sort of thing, they're triggered, so to speak, with that. Specific to the complex PTSD from the prolonged trauma, they will also have difficulty with behavioral and emotional regulation. So that leads to unstable relationships. It leads to them experiencing a lot of physical symptoms that might make them feel like they have something physically wrong with them when they don't. So the chronic pain, stomach upset, and you can dig and never find a cause. It's really kind of the brain's inability to appropriately process the emotions that they're experiencing. So as far as treatments for them, there's actually a vast array of options for them. I think that the most prominent one these days that's gaining a lot of ground is something called EMDR. And it's basically having them walk back through their experience while they're watching the therapist's finger moved. And that seems like total hocus pocus, because it's like, what in the world would that do for anything? But there's some proof that it actually helps them basically ground themselves in the moment as they relive it, and help them kind of integrate what they're experiencing and be able to better process it. The finger movement keeps them in the moment while they're experiencing these awful things, to help them remember this is in the past, you're here in the moment. I may not be explaining that well, but anyway, it's turning out to be really effective, so that's good. The other therapy forms, there's a trauma-focused cognitive behavioral therapy as well, and exposure therapy, which isn't as helpful in the prolonged trauma instances, because you can't really expose them to that again. But expressive psychotherapy, or talk therapy, which is what most people do for most anything, just talking through things, doesn't seem to be quite as helpful as the other forms of therapy. It just kind of, makes them relive it without actually integrating anything. Especially in the immediate aftermath, there's for a long time thought to be that if they went through talk therapy in the immediate aftermath during the acute stress disorder phase, it would prevent PTSD prolonged, and that's not the case. Medication-wise, so in the early aftermath in acute stress disorder, the benzos like the Xanax, the Valium, can be helpful, used sparingly, but you don't want to stay on that long term. The same drugs we've been talking about, the SSRIs, SNRIs, the Lexapro, the Effexor, all of those are helpful to an extent. A big one for them is sleep. trying to make sure that they get healthy sleep, because the flashbacks and nightmares and things tend to prevent them from sleep, which is just generally awful for your mental health anyway. So, we utilize several things for sleep. It gets a little more problematic in the geriatric population because a lot of the sleep medications have bad side effects for you guys, but mirtazapine is a really common one and fairly effective one that gets used for this, and trazodone is another one that we can go to if need be.
Alrighty, next slide. Alrighty, now we have obsessive compulsive disorder, which typically gradually occurs from childhood to early adulthood. You're not likely to have it late onset. It's probably something you've probably been dealing with for a while, and it occurs in about 2 to 3% of the population. Typically, you'll have some kind of comorbid conditions such as depression, other anxiety disorders, eating disorders, tics. It can have a genetic and familial component. You'll probably notice that with all of these, it can be genetic. Let's see. And it's slightly more common in females than in males, and also more common in firstborn children. For males, typically occurs in childhood, and 60 to 70%, we mentioned the comorbid anxiety or mood disorder. And 30% of the time, there is a coexisting personality disorder as well. Besides just the obsessive compulsive disorder, there's obsessive compulsive personality disorder.
You want to clarify the difference?
I'm going to have you do that.
Okay. So, as far as obsessive compulsive disorder, I feel like this one gets thrown around a lot. Well, I'm OCD. I like things organized and cleaned. That is more along the obsessive compulsive personality disorder. The actual obsessive compulsive disorder, without the personality part, is extremely detrimental to people's lives. They have a hard time functioning because they have such intrusive thoughts. If I don't do this, then my mother's going to die. Oh, I think I just hit somebody back there. Let me circle the block 58 times and be 2 hours late to work because I can't get past this thought. So two very different things.
Yeah, so that's kind of going into the symptoms. One thing I always think of is someone who locks the door multiple times. Otherwise, if they'll lock it 3 times, and if they only lock it once, they're always thinking about it over and over again throughout the whole day, and they get anxious that someone's going to break in because they didn't lock it those 2 extra times. And that affects their thought processes. They get worried that you doing something as small as locking my door is going to lead to someone having an accident or falling or something like that. And these behaviors can take up to over an hour a day. So instead of locking your door 3 times, you're locking it like 60 times. They take up a long period of time, and they have to be done in order to relieve that anxiety of what could happen if I don't do this. They typically occur waxing and waning, so they occur sometimes. They don't occur at times, although typically it can just be steadily getting worse. So at one point, like I said, you're locking the door, and the next thing you're driving the car around multiple times. So it can slowly get worse as time goes on. And it can be associated with early onset dementia. So people, when they start losing that memory, you can think like, oh, did I forget to lock the door? Let me do that more so I can remember better. As far as treatment, as far as medications, it goes along with some of the ones we've talked about already. Fluoxetine is a SSRI. Sertraline is another SSRI. Fluvoxamine and clomipramine, those are the MAOIs or monoamine oxidase inhibitors. These have a lot of side effects, especially causing really high blood pressure if you eat something like chocolate or some kind of meat. It can cause really high blood pressure, which can lead to other problems as well. And then for treatments when these don't work, you can use Buspar, your Valium, Ativan. Your neuroleptics such as Depakote's one, right? No.
Yeah, any of the what we would think of as anti-seizure drugs, but they're also mood stabilizers as well.
Yeah. And deep brain stimulation, which is something I forgot actually works for that. And then, but typically, like I said in the beginning, just giving medications alone is not necessarily going to help. And especially with obsessive compulsive disorder, you typically need the therapy component as well in order for it to be really effective. And so different therapies that we use the exposure therapy, exposure and response, just kind of having someone, do the action normally and then have them walk away. And the more you do that, the more likely they're to notice that nothing's happening and that it's okay to just do the action once or not to worry about it at all. Cognitive-based therapy, like we've mentioned for almost all of these anxiety disorders. A diary, keeping a diary just to when you notice you're stressed out by something, when it comes to obsessive compulsive disorder, just writing it down can help. And then trying to substitute different activities or new activities for those compulsive behaviors. If you substitute something new that's something productive, it can actually help with OCD.
I think that's what we have. We're happy to take questions.
I'll tell you a quick story on myself. 15 years ago or more, I was putting my house on the market after a house I'd lived in for 28 years, and I needed some help cleaning some things out. So I had my daughter come help me. She was alarmed to see all the stacks of things I had. I said, well, these are important files. These are newspaper articles I don't want to lose. I wouldn't. Anyway, she says, I said, so I'm a little bit of a pack rat. She says, Dad, I think being a pack rat is about a half a step from being a hoarder. Okay, I cleaned everything out and threw it all away. Yes, sir.
What do you?
You're saying mirrors? Mirrors? Yeah. Mm-hmm. So mirrored, in other words, seeing your parent do it maybe, and then finding yourself, rather than being genetic so much, it might be just modeling or, yeah.
I think, that's a great question. I think there's not necessarily a percentage number answer to that, but I think that is part of it. When you grow up around a certain environment, and the big thing in all of medicine, not just in anxiety, is your kind of genetic versus your environment. If you're in an environment where you only experience to a certain anxiety disorder, you're more likely to have it. It doesn't necessarily need to be like a certain gene or something that's in your DNA that leads you to be more likely to have it. When you can learn these disorders as well. That's what I'm trying to say.
So yeah.
Yes.
This may be a whole nother day's topic, but on every disorder, you said women are more inclined. Why?
Fair question.
That is a
Careful,
very good question.
careful.
I'm a woman, so I can say what I want.
Hey, it's safe, maybe.
Honestly, I'm not sure that we have a great answer for that. It could be that hormones play a role. I don't think that there's been a ton of research into that. Could be that we're just neurotic. I don't know, but no, I think.
Could it be as simple as just more sensitive?
Yeah. I don't know. I think that more research definitely needs to be done into that, because you're absolutely right. That's very much a trend, for sure.
Good question. Yes. We want to hear every word, Helen. You can hear it.
She stole my first question. Anyway, I have read recently about the fact that dying of a broken heart is a real phenomenon, and it takes place mostly in women. What's the physiology behind that? What really is happening there?
I'll give the experts a chance first.
Oh, the experts. Well, he's a cardiologist, buddy.
No, I'm not a cardiologist. Well, I think that's kind of going into what's called Takotsubo cardiomyopathy, which is basically the muscles in your heart gets affected by stress. Now, it could be the stress of a broken heart. It could be the body having an illness of sorts. But as far as to why, you know, women are more likely to have that, and I don't know if there's a good answer for that. Mm-hmm. Yeah. Mm-hmm. Yeah.
So it's probably excessive adrenergic. I mean, you can imagine some mechanisms, Helen, and whether they've been proven that way or whether there's an established explanation. That's what I'm not aware of. I've heard it too, but I haven't read about it in depth. It's easy to imagine that, you know, the epinephrine-like chemicals in our body that are you know, in high levels under certain stressful circumstances, remodel the heart muscle over time to the extent it's excessive and frequent, that kind of thing. I imagine that's the basis, but I'm just speculating. I haven't really read primarily on it. So, but I have heard, so I know that it's an established diagnosis now. So,
Yeah, I've actually treated 3 different women with it in my time in residency, so.
no, say that again.
I've treated 3 different women with Takotsubo's.
Then you have no excuse. Then
I,
you have to have the answer.
I have not read any specific research either, but my theory would have been that when you're so stressed out, you've constantly got these levels of adrenaline and you know, ramping up, keeping the heart rate pumping fast, keeping the heart rate fast, keeping the heart pumping hard, and eventually it's just going to wear out and kind of give in, and then you end up with this form of essentially heart failure called Takotsubo's because the heart's just tired.
Yeah, if that's the case, I imagine one of the medications is a beta blocker.
I'm sure, yeah.
Okay.
I'm sure, yeah.
So one of the interesting things that I've had a friend experience, and I bet there are people here who either know someone or have had the problem themselves. She talked about situational and performance-related anxiety. So getting up, public speaking does it for a lot of people. Performing, you know, musically can do it for some people. And it's well established that taking a beta blocker, which that would be like metoprolol, Lopressor, Inderol, atenolol, those kind of medications before a performance, it slows your heart rate down. It basically blunts the adrenaline-related surge that happens that causes all those symptoms that, you know, that you have, the racing heart and everything else. And it really works for a lot of people, just to have that in your system to blunt that. So, and this may be just a smaller version of what some people are having constantly and affecting their heart long term. I saw a hand back here.
Takotsubo.
Oh, yeah.
She's asking what that specific heart failure, the broken heart disease, was called officially. Takotsubo. It's Takotsubo.
Ellis, was that you? Did you have your hand up? No. It's also here. Yes. Let me give you this.
Can you tell us anything more about claustrophobia?
Yeah, I guess
About
we
being afraid to be in an elevator and things like that.
Yeah. So I kind of grouped all of the phobic disorders into one big thing, but you definitely have a variety of different forms. He mentioned
That's one of the more common ones, isn't it?
That's that may be the most common one, honestly. But it's kind of in line with the rest of them as well. Just kind of exposure response therapy is going to be your most effective thing. So allowing yourself to be in a controlled environment where you're enclosed in something to realize that nothing bad's going to happen. If you do that over and over and over, it eventually kind of blunts the response. There's really not a lot of medication that can do a ton. in the phobic disorders, the therapy is the mainstay for sure. And that's definitely the same in claustrophobia as well.
And having an open MRI.
Yes. Yeah.
That's one of the ways we see it pretty often, isn't it? Yeah, I bet it is the most common phobic. That and fear of heights, maybe, do you think? Can you think of others?
Snakes, mice, spiders.
Spiders, yeah, and snakes. Yeah. Yeah. Yes.
Well, I've got several questions really, but one of the questions I would love to have answered is why is it when you get an SSRI or some of these other medications, it takes weeks and sometimes a month or two for them to have any effect?
I'm not sure I know the specific physiology behind that. I'd say that it's kind of replenishing a previously existing depletion of it, would be my guess. So if you're depressed, you're at a low baseline, and it takes a while to build back up to normal.
So if you look at the brain as a whole, there are mechanisms in place that the body makes to remove extra, neurotransmitters like serotonin for an SSRI. And so when you first take a medication that's supposed to block, the cells from taking that back, you still have those parts that are outside the cell that are still clearing it up. That's why it takes a longer period of time to slowly increase the levels of serotonin to try and get that therapeutic response.
Thank you. And if I might ask another question, I have been reading lately about something very, very interesting, and particularly in regard to the kind of drugs you're talking about, the psychotropic drugs. And that is the fact that with the whole advent now of individualized medicine, this is particularly important in that in order to really know which psychotropic drug and how much of that drug to give or not give a person now can be determined to some extent by their genetic profile. What do you think about that?
I've definitely seen it utilized a lot more and more as I go through training. It can definitely be effective in people that are resistant to treatment. If you're trying the mainstays of things and they're just not responding, you look at their genetic makeup and it'll tell you how their body processes certain things. So there are certain proteins that help break down the medications in the liver, and if they have more of this one than they have this other one, then they're going to process this medication differently than that medication. And so having that information in front of you is very helpful in trying to tailor their treatment to what's going to work best for them. And I will say, along the same lines, looking at family members' responses to medication is a nice quick way to avoid doing all that DNA analysis.
And it also makes things faster. I mean,
Yeah.
typically when you're started on an SSRI, you're given a month trial or 6 weeks, 8 weeks to see how it works. Then if it isn't working well, they may increase the dose. And you can imagine how long it takes if we keep increasing the dose or adding another one on top of that. It is to really get the medication that works best for you. So having genetic data that allows us to quickly get to that medication that works for you makes things a lot faster and will make it better for patients in the long run.
Takes the trial and error out of it, which is really nice.
So this is the area called pharmacogenomics. And I don't think, there are very few people, except in very large tertiary referral centers and research centers, that have had a lot of experience firsthand. So I don't know how reliable what you just said actually is in practice. I mean, you'd like to think it works that way, but so what I do know about it, just in terms of what the experts are thinking right now, so we were considering a contract with a company that would do this kind of testing here, specifically over in HCC, before we started. These, the irony, these kind of medications, these psychotropic medications are a double-edged sword. Every medicine is, but these psychotropes, you hope it does the right thing, but the desired thing, but the kind of side effects they can have can be terrible. So you want to be very smart about this and careful. I talked to, so the Associate Dean of Medicine up here at UAMS Northwest Linda Worley. Some of you may have met her. She's a psychiatrist by training. Well, she's got all these high-level, well-positioned colleagues all over the country. She sent an email out to about a dozen of them. And so we're talking about at Menninger, at Mayo Clinic, at Cleveland, all these places. And so they all sent me these personal little responses. Well, we do them because, you know, we kind of have to be able to claim that we do everything, but we don't much believe in it yet. You know, we're going to have a lot more experience to, and the truth is that you can usually figure out what's best without doing this. That wasn't everybody, but that was a few of the comments, but all of them expressed a reservation. We're not quite there. It's going to take more studies to convince us that it's you know, the way to go, because I think what I read between the lines was the fear of a slippery slope. Once we all jump on this bandwagon, no one's going to come in that doesn't get this horrifically expensive testing. You know, and then then once you get it, you're almost compelled to do that, even if you don't really believe otherwise that the person first ought to be treated that way. So we're at a place, I think it's very exciting, because I do think once they figure all those questions out and the answers to them, I do think it's a way for the future. It's an exciting way for the future, but I'm glad there's some people in places like that that are conservative enough to say, we're just going to be careful about this. And we, by the way, have that capability now. My resistance was I didn't want it done automatically on everybody. Let's pick the cases we do it on. I mean, why should we be more proactive than managers? So anyway, that's what I can say about. What was your first question? I think that is, I think mapping the genome started something big. What was her first question?
Oh, it was the, why does it take long for the SSRIs to work?
Oh, you know, the SSRIs and why they take a long time. I mean, that physiologically is the way it works for most people. It's what all the studies show. Although and I think your explanation is about as good as any, but I'll have to tell you, when, you know, the first SSRI was Prozac. It was the first one available in the community. And from the time we all started using Prozac, which was a miracle drug compared to what we had before that, and then the later members of the SSRI family are just kind of improvements on Prozac in different ways. But you would warn people that it's going to take a week or two to begin to have effects. And I cannot tell you how many people came back to tell me after the first day I felt better. Now, is that placebo? And I still have people say that when we start an SSRI. Not quite as much as right at first, but so I think sometimes a person, and again, I don't know whether it's placebo or really is some early effect is happening away from the usual metabolism. So. Oh, and tell me the word again.
I have read that it might be due to neurogenesis, that the drug is really promoting the multiplication of neurons.
I can't say that's wrong, that's for sure. That's interesting, isn't it? Fascinating, really.
Got a question over there.
Yes, ma'am. I'm going to hand you this if I can get it to you. Can you reach that?
My knowledge of the things you're talking about is pretty small, but something that was just said made me think that if I knew that my mother or her mother were had problems with this medication or tended to this thing, you know, in this mobile society and at our age and stage, how many of us know what our mother was allergic to or what our grandmother or whatever, that sort of thing.
Yeah, that's a fair point.
And it kind of reminds me of the comment a while ago, the mirroring idea. I think we all see ourselves developing habits very like our father or our mother. So that's a part of it that I believe is real too. Okay? Yes.
I am so much more anxious after coming here and seeing all these pharmaceuticals that are out there. I mean, what is wrong with us? Human beings, surely there's a better way. And I think we've forgotten how to be real with each other for fear we're not going to be accepted. And so if we had a lot more understanding of our fellow man, we wouldn't need nearly as many drugs. That's my short sermon.
Well, my only caveat to that is I don't disagree with you, but mostly what they were talking about here is disorders. These are things that happen to people, not for failure of, some personal flaw of behavior. These things that they're susceptible to genetically or otherwise. Not all of it. Some of it is certainly our frailty and inability to cope in a stronger way, but so much of this is through no fault of anybody's. Like so many diseases that we're prone to, and there are a lot of days I feel like just the way you do about pharmaceuticals. I wish I didn't have to use this script pad, and there are other days I'd say I sure would hate to practice medicine without it because you see so many benefits too. So, but it's a reminder, and it's especially true in the age group we're all, most of us, with them being exception, are in this room. Every medicine is a double-edged sword. You hope it does what you desire, and you fear that it might, and have to be vigilant about the possibility of it backfiring in some way. So it's just the reality. But the benefits are impressive, obviously, in so many things.
And I think that kind of leads back to reiterating that, yeah, medicines, they can be great, but they're not the only treatment. When you mix medicine and therapy together, that's when you really notice a difference. You may get a partial response with just medication. You may get a partial response with just therapy. But when you put the two together, you really notice a bigger difference.
Mm-hmm. Good point. Yes, ma'am. She's reaching.
Can these psychological problems cause physical problems? For instance, can extreme anxiety cause you to lose your hair?
I think I know his answer to this one. Do you know, not only is it yes in capital letters, but that's another thing that happens to every last one of us as we get older, is an increasing likelihood that our psycho and emotional aspect of our life is going to play out in physical symptoms, and our physical problems are going to show up with depression and anxiety and things like that. We're a complex, holistic sort of animal, and it's part of the fascinating physiology of human beings. But I think absolutely yes. Absolutely yes. Any other questions? These are such good questions. Now, I told you not to sit on the back pew here. Yeah, I know. Aren't you true? I wish you hadn't mentioned it.
This is for the young doctors. When y'all give these talks and you see the aged people in here, does all of being more aware of the problems of aging that y'all see every day, does that make y'all more concerned about aging yourself?
I'd say that you guys are pretty good examples of aging, especially the population here. Compared to kind of what we see in the other places that we work at, you guys are a great example of what aging can be if you take care of yourselves.
Yeah, trying to recruit residents out here to do more rotations. I'm like, they're the ideal patients. They're like the healthiest people you will ever encounter at this age, especially. So I aspire to have as few health problems as a lot of you do. Y'all are incredible.
It seems like every day, it's certainly every week, I'm saying something to someone that you make 90 look awfully good, you know. And there's so many examples of that at every age level out here that they don't get to see otherwise. You know what else I hear constantly from them is when they do clinics elsewhere, obviously, not just here. At Butterfield Trail, there's not a problem with compliance. Patient compliance, you know, if I do have to prescribe something, if I can't tell you how often I'm saying, I should have warned you, this medicine hardly ever works if you don't take it. You know, you don't have to, out here, that's not a problem. People are so compliant, and people are conscientious about their health, and they're interested in, and what they want the help and advice, and so they comply with what your recommendations are, and that's rewarding, and it's a little exceptional from some of our other clinics. So I really appreciate that about it.
Yep, we do.
They go to the VA. Their inpatient experiences are at Mercy Hospital and the VA. And they do hospitalist work, and then they also do electives and different specialties at those two campuses also. Yes, Ellen?
Some end comments here. One of the things I want to tell Dr. Wright and you two interns, you're the best thing that ever happened to Butterfield. Amen. We absolutely think it's wonderful. And well, and I want to quote something that a friend of mine said, who is a resident here at Butterfield. She says, "I'm so glad we have Dr. Wright, because a Dr. Wright can never be wrong." I'm not through. And I want to say directly to the two new doctors, and that is that you have a wonderful, wonderful future ahead of you in what medical science is going to accomplish. And marvelous things are happening in the way of vaccines and new treatments against cancer, understanding more about the neurology of the human condition. And so you are going to have a wonderful experience, I think, in your profession. But we're so glad to have you here. And again, I think that our clinic here is the best thing that ever happened to Butterfield.
You are so sweet.
Thank you.
Thank you. Well, thank you all for coming and participating. Can't tell you how uplifting it is to just interact with you guys. I tell them all before they get here, the ones who haven't been here before, you are going to meet the savviest patient mix you've ever seen. These people know about, they want more details and they want to connect the dots, but you're not going to be talking to someone that doesn't know something about health. So I appreciate that. That makes such a difference for them and their experience. Thank you so much.